good evening, everyone. Welcome to our Scope of Practice webinar series, episode 3, the final episode in our 3-part series on scope of practice issues. So today we're really focusing on how we can fix scope of practice issues. And then what does a perfect working relationship look like between emergency medicine physicians and then other providers in the ER. So as always, it's us three here today moderating this discussion. My name is Andrew Sweetjack. I'm a second-year medical student at Rosalind Franklin University, Chicago School of Medicine. If my colleagues could also introduce themselves.
Hi, everyone. My name is Edlita James. I'm M4 at University of Illinois, technically a PGY0 at the Ohio State University in the summer.
Hi, everyone. My name is Katie Stevens. I am a third-year medical student at Ross University School of Medicine.
Great, thanks, guys. And then our panelist tonight, again, is going to be Dr. Natalie Newman. She's not here right now, so she'll be dropping in late when she gets the chance. And then we also have Dr. William Sullivan. And I'll read your bio really quick. So Dr. William Sullivan is an attending emergency physician at St. Margaret's Hospital in Spring Valley, Illinois, and he's a clinical assistant professor of emergency medicine at Midwestern University. And he's got a private legal practice where he represents medical providers in matters such as contract negotiations, medical board issues, medical malpractice complaints, and other issues related to the practice of medicine. He regularly publishes articles on medical legal topics on his blog at sullivanlegal.us and an emergency physician's monthly magazine where he's a senior editor. He's a member of the AEM, the American College of Osteopathic Emergency Physicians, and the Illinois State Bar Association. And he frequently lectures on medical legal topics in forums ranging from medical schools to residency programs to state and national organizational meetings. Thank you, Dr. Sullivan, for joining us tonight.
My pleasure. I hope I can live up to that awesome introduction.
I'm sure you can. All right. So this is just a little layout of the land as far as how we're going to take things tonight, and depending on when Dr. Newman shows up, we may switch some things around. But again, we're really looking for we're really looking to have a discussion and come up with an answer as to what does a perfect working relationship between physicians and nurse practitioners and PAs look like, and how we can advocate for physician-led teamwork. And so now that we've done our introductions, basically we're all going the order of as follows. We'll start with how can we fix current scope of practice issues? Then we'll discuss what does a perfect working relationship look like with NPPs. And then we'll touch on a little bit about HPEM at AEM 23, which we've spoken about through our first 2 episodes. And we're also going to have a quick discussion on thoughts regarding Match 2023 as it relates to emergency medicine, which I think is appropriate given that data just came in. And so we'll speak on that a little bit in this presentation. And then any time for questions or any questions we have, we'll also address, and then have a few closing messages tonight. So we're going to start off with just the question of how do we create an ideal working environment in the ED with non-physician providers. And Dr. Sullivan, feel free to speak on this in any way you'd like to, and we'll see if Dr. Newman comes in to back you up a little bit.
Sure. So I think when we talk about how do we create an ideal working environment, we got to define what an ideal working environment is. And figuring out that definition, I think it depends on who you ask. So if you ask a hospital or a contract management group, they're going to say the ideal working environment is as many APPs as they can staff with maybe one physician supervising them because it costs less money. If you ask a physician, they're going to say, well, obviously we want physician-led teams and we want mostly physicians and minimal input from medical providers. If you ask a patient, you don't know what the answer is going to be. Do patients want physician-led care? Or do they want APP-led care? So it's in determining what the ideal working environment is, you kind of have to define it first. And so, I'll throw that back to you guys and just see what do you think.
I think when I think about ideal, I think of everyone kind of knowing, I don't want to say their roles, but at least their knowledge base and when to reach out for more, right? To say, I don't know, whether that is a physician to physician or nurse practitioner or physician assistant, to their supervising physician. I think it's just more of being honest about what you do and don't know. I think that is really what's ideal, and being honest in who you are and what you can do for a patient, I think also.
So I'll give you an example of a lawsuit because I'm a lawyer. I love looking into lawsuits and stuff. So there's a case that happened, I think in 2000. The jury verdict report was from 2016, so it happened several years before that. But a patient comes to the emergency department and gets sent to fast track, complaining of pain in his leg after he's out playing soccer. Now I think it was a physician assistant that saw the patient, diagnosed with a leg strain, sent him home, anti-inflammatories, follow up day or two if you don't feel better. So is that outside of what you'd expect a physician assistant to know about and to be able to diagnose? Probably. But then the kicker is the patient just didn't have a leg strain. The patient had non-traumatic compartment syndrome. And the patient went home, wouldn't go back to the emergency department because he said it was just a leg strain, went to an orthopedist the following day. The orthopedist immediately diagnosed compartment syndrome, took him for an emergency fasciotomy. But unfortunately, the patient ended up with chronic regional pain syndrome, which then caused chronic back pain. Ultimately, there's a lawsuit. The patient won a verdict of $7 million for the chronic pain. Now, 40% of that was attributed to his own negligence for not following up, even though he's continuing to have pain. 20% of that was allocated to the physician assistant who missed the diagnosis, but 40% was allocated to the emergency physician who signed off on the medical record without even reading the note, because they said if you read the note, you probably would have realized this was compartment syndrome. You would have had the patient come back sooner. So I agree with you that it would be nice if everybody said, okay, we agree. A perfect working environment is we agree that we're going to ask for help when we don't know something. But part of the problem is if you look at the amount of training that NPs and PAs have versus physicians and even residents, in a lot of cases, NPs and PAs don't know what they don't know. And I know that's a kind of a broad statement. I don't mean that to say that every NP and every PA has less clinical acumen than a physician. But in a lot of cases, especially new grads, don't know what they don't know. So an ideal working relationship, that may not be the best definition of an ideal working relationship. So what else can we say is a good working relationship? Nobody else is going to chime in. So I'll give you guys a couple of thoughts. I know other systems because I've read a lot about it, and other systems or other processes that work for other systems. And one of the other systems is that NPs and PAs have more of a role in follow-up care, not in new patient visits, not in like high intensity patients that maybe have a lot of different medical problems that interact, but in chronic stable patients, they have more of a role in caring for them. Or for example, in psychiatry, if someone has a chronic stable problem, they're on medications and they're just doing a follow-up visit, if there's no new complaints, those patients may get fast-tracked to an NP or PA instead of having to wait for a physician. Or surgical follow-ups, if there's routine surgical follow-ups, those type of things. When there's new patients and new problems or undiagnosed problems, I think it becomes more of an issue of is there a wide enough differential diagnosis in some cases to make the idea to catch any potential of uncommon medical issues that maybe don't present as a typical thing, like we were talking about this past patient who got diagnosed with a leg strain that was compartment syndrome. So so that may be one of the things to one of the goals is to say, hey, maybe we say here's a type of patient or a presentation that is ideal or that isn't ideal for independent NP or PA practice.
So I have a question. With that being said, you're saying that you're seeing more of the role for the non-physician provider being more in like a stable, like follow-up kind of role. So are you saying then that perhaps they're best utilized outside of the ED or even outside of urgent care? Is that what I'm hearing?
It's tough to say because, you know, the emergency department, especially now, the acuity is going up, the number of patients are going up. So is one physician going to be able to handle a lot of patients effectively? Maybe not, but I think personally, I think that a better role, instead of saying, okay, NPs and PAs can work in a fast track and patients who are triaged fast track get assigned to them and then the physician signs off on the chart at the end of the shift. I don't think that that's an ideal working relationship, but I think more of a better working relationship is working side by side with somebody, running every patient by the physician, and having a physician lay hands on every patient that comes to the emergency department. You got to look at the patients. So there's and there may be circumstances where you can't do it, but then it just becomes an issue of trust. Do you trust the provider that you're working with?
Dr. Sullivan, we have a question in the chat, kind of like a question comment. So she says, perhaps another goal being initial triage being led by physicians, or perhaps limiting how many APPs or NPPs a physician is overseeing so they have time to review the charts and be involved in care.
So I think that's heading in the right direction. Initial triage. So I think if you look at the initial triage having to be completed by a physician, yeah, that's great. So you're going to do the initial history and physical exam, but then that really doesn't leave much left for an APP to do, except maybe say, okay, here, create the discharge instructions and write on any prescriptions. And I don't know that that's really an effective use of the capabilities of an NP or a PA. So in terms of how many physicians or how many APPs a physician can oversee, I know at least in Illinois, now keep in mind, there's some states where NPs have independent practice, and there's actually a couple of states now, I want to say, I think Idaho and South Dakota, I don't remember exactly, but there's a couple of states now where PAs have independent practice authority, and they don't need that oversight. But if a physician is going to agree to accept responsibility for supervising an NP or PA, they also really need to make sure that the physician has a good grasp on what's going on with the patient. And in terms of how many physicians or how many NPs or PAs a physician can oversee, there's actually a legal case about that. And I want to say it was in California. And it was like a $21 million judgment. I had it pulled up. I'll see if I can find it real quick. Yeah, it's $21 million. It was in Texas. There was a physician who was supervising 4 CRNAs to perform surgeries, and one of the CRNAs forgot to turn the patient's oxygen on, and he ended up brain dead. And the plaintiff lawyer argued there's no way that an anesthesiologist should supervise that many CRNAs at one time. So, and again, it was a $21 million judgment. It just came out, November 2022. So, yeah, there should definitely be a limit on them, or on how many NPs or PAs a physician supervises. But just keep in mind that in the states where there's independent practice, there's not that supervision requirement.
How do you know how states come up with how many numbers of NPPs if one physician can oversee? Like, I believe Florida now has 10. One physician can see 10 NPPs. How do they come up with that number?
Yeah, I don't know. And it's kind of interesting that I practice in Illinois, and Illinois has changed it from, it used to be 3 and then went up to 5 and then it went up to 7 and now it's up to 10 that's a physician can supervise at one time. So I don't know how the legislatures come up with these numbers, but that's up to the legislature in each state. I'm going to try to get the link to that because someone asked if we could share the link. So I'm going to. So, what else do we want to? So when we, any other ideas about what an ideal working environment with non-physician providers might look like?
I think to me, like walking into an emergency room and not having this stigma of, oh, it's us versus them, and having like some kind of cohesive, like walk in, we're a team, to me is a perfect working relationship. We're not against each other. And I feel like the scope of practice issue creates that barrier. Like you said before, NPPs don't know where their scope of practice ends. And I feel like that is a big part of this us versus them. I hear all the time, we're just the same. And it's how do you come up with that? How do you come up with we're the same? It's silly.
Well, and so I think that just the same thing is, I would disagree with that as well, because if they're just the same, then why would, if, for example, I'm working with another emergency physician, I don't have to supervise his care because we're the same, we have the same training. But if I'm working with an NP or a PA, I have to supervise their care. So if they're just the same, then why would a physician have to supervise their care if they're just the same? So that, to me, that's I would disagree with that statement.
All right, I'm going to advance the next slide. Thank you for your insight so far, especially on that first question. That was really good. So now let's kind of move more into how our audience, which could consist of medical students, residents, and physicians, advocate for physician-led care where they are training, and any particular organizations or resources we could join and take advantage of.
So when we talk about how do we advocate for physician-led care, you have to look at who the players are and who makes the decisions. So I think being a member of organized medicine and giving organized medicine a stronger voice is helpful, but ultimately organized medicine doesn't make the decisions on how many physicians are staffed in a department, what physicians can do versus what NPs or PAs can do. That's actually made by legislators. So, for example, there's, and again in Illinois, but I'm sure in every other state they have the same type of idea. There's the Nurse Practice Act, which defines what a nurse can do. And part of the Nurse Practice Act actually has a section for advanced practice nurses. So, and here's another, I'll send the link out for that one and the link out for the PA Practice Act. So every state, and there's a Medical Practice Act too. So the legislature is actually the ultimate determination of who can practice in what circumstances and who needs supervision. And policies by medical organizations may provide a little bit of a persuasive argument that things ought to be one way or another, but ultimately the legislature determines who has what powers. So legislatures are the biggest player, and the only way to really influence a legislature is either by influencing their constituents, each constituent in each legislator's district, or by lobbying. So, and that's something that I think would both the physicians singularly and the medical organizations would do a better job, or they would be more effective if they'd focus more on that. So who are some of the other players? One is the hospital CEOs and the hospital medical board, or the hospital boards, that decide, okay, here's how we're going to staff our hospital, or here's how we're going to staff our emergency department, and what's going to influence them. I mean, they're going to want to try to save money because obviously it's a lot more expensive to staff somewhere with a physician versus a NP or PA. It's about NPs and PAs are about a third of the cost of a physician. So they're going to want to staff more NPs and PAs as long as there's not any downside to that. And so part of getting hospital CEOs or hospital boards to change their mind is showing them, well, maybe there's liability associated with that. Maybe patients will be upset with that, or maybe it'll cause physician attrition, which they don't want. So that's another player. And then you have, in a lot of cases, you'll have contract management groups. So for example, in emergency medicine, there's four or five dominant contract medical groups and contract management groups. I'm not going to name any of them, but we all know who they are. And obviously they want to make a profit. So again, if you can staff an emergency department, a busy emergency department with one physician and a couple of NPs or PAs, then ultimately you're going to make more profit doing so because you don't have to pay for as many expensive physicians. So I think those are the players, and then it's just a matter of figuring out how do you influence the players to encourage them to create a physician-led team.
We have another question in the chat. Is there any way that physicians could refuse to sign off on NPP charts where they were unable to see the patient and review the case without repercussion from admin? It comes from an example at a previous event. They heard about how some places essentially force physicians to sign off on charts, which ultimately puts their license at risk. And would standing up to this have any kind of be effective or lead to consequences for the physician?
So is there a way that physicians can refuse to do it? Yes, they can refuse. They can tell either the hospital or contract management group before they join the staff or join the group that they're not going to do so. Now, the hospital or the contract management group may say, well, if you're not going to do that, we're not going to hire you. And then that's ultimately becomes an issue of who is more in demand? Is the physician who is going to work and not sign off on charts more in demand, or is the hospital or contract management group going to be able to find someone else to fill that spot that will sign off on the charts? Now, once you sign a contract, I do a lot of contract reviews. So usually the terms will say you agree to supervise any non-physician staff that you work with, and it may say that you agree to complete all paperwork that is necessary for billing. And there's all kinds of little contractual agreements that you have to sign. So if you don't sign off on the charts, then they can allege, well, you're breaching contract. And if you don't do it regularly, then it may give either the hospital or the group cause to terminate your contract. So it's better to address the issue before you start working for a place rather than trying to address it once you start working there and you don't want to take the liability.
I think I wanted to ask, you were saying, it's all about influencing the players, always trying to figure out who the players are. And I just wanted to know, when you were saying like organized medicine can do a better job of lobbying, which I totally agree. I think, but in the public sphere, physicians, there is a negative bias in terms of, well, you guys get paid well, and you're just hating it. It almost comes off as you're just, kind of wanting to just stay the top dog just to be that. And you're not allowing other people to like do these things that they can do. So I guess my question really is, how do you change this public perception where people are struggling, everything's going up, inflation is high. And so they look at those who are making a lot of money in terms of like the attendings, and of making the assumptions that, physicians are just way up there and, they just want to stay on top. It's all about money for them, right? So how do you change that perception, with those that you're trying to influence, especially in legislature where they are getting heavy nursing lobbying, they're getting that heaviness of the PAs and they're the underdogs and they're helping save money and, they can do a lot of things that physicians do. How do you fight that when there's, in a lot of realms, this negative perception of physicians just wanting to stay at this top?
Well, and I agree with you. I think that there's more of a negative impression of physicians in the public for the past few years with everything that's happened with COVID and vaccines and masking and all these other issues. But so I think that you remember when we first found out about COVID, I mean, people were out and cheering in the streets and banging pots and pans from the windows and saying how great medical providers were. And then within a couple of years, now they loathe us, they don't trust us and everything else. So we've got a lot of damage control to do even in that respect. But when you talk about, hey, everybody looks upon the physicians as being greedy, I think you need to reframe the argument. How do you do that? What are some of the other issues that are involved with NP and PA care versus physician care aside from money? Training, right? I mean, you look at the amount of training like residency training for a physician is 4 years. Now, think about if you're an NP or PA and you say, okay, I'm going to work in family practice for a little while, but I don't like it. I want to go to the emergency department. I mean, literally, next week you can go and apply for a job in the emergency department and start working in the ER. What if you're a physician and you want to do that? Not so easy. You got to go through another 3 years of residency to become board certified in emergency medicine. I know some places will hire family practitioners or internal medicine docs to work in the emergency department. But what about surgery? Say if an NP and PA wants to go from emergency medicine into surgery, they go and apply to a surgical spot. If an emergency physician wants to go and be a surgeon, you got to do 4 more years of residency. So there's something to be said about the amount of training that's required. So I think that's one thing that could be emphasized instead of money. And if you want to talk about money, there's a lot of studies that are coming out now that show that NP and PA-led care isn't actually cheaper, that it's more expensive, that they refer to the emergency department more often, that they order more high-cost testing like CAT scans and stuff like that. So there's an argument that it can be made that maybe you're not saving as much money as you think you are. And then, I mean, safety is another issue, and I'm sure that there's documents out there, and I don't know every single study, but just in terms of what's the likelihood that a physician's going to miss a given issue versus an NP or PA. But if you focus on issues other than money, or you use other studies that say, hey, there's money that's, or there's the amount of money you think you're saving, maybe you aren't saving quite as much. Those are all, I think, arguments that you could advance, again, using proper statistics to back those up. But those are arguments you could advance to say, hey, physician-led care is actually better care. And better in quotes, because you got to define what better is.
With all this lobbying that, NPPs and nursing, nursing has a huge back on them to advocate for their agenda. Do you ever see insurance companies coming to bat for the physician side? Since
insurance companies are going to look out for the insurance companies. There's kind of a conflict with physicians, because insurance companies want to bill patients more for their premiums, but they want to pay physicians less for their care so that they get to keep the difference. So I don't think there's ever going to be a situation in which insurance companies say, we want physicians more than we want NPs or PAs. They don't have a dog in that fight. And insurance companies may actually say, hey, if we can pay less for care for an NP or PA, then maybe it's to our advantage because we'll earn more money by doing that. So there may be an incentive for insurance companies to say, hey, we're going to back the independent NP and PA movement.
Even if you have a patient that has continuous follow-ups after being seen by an NPP and maybe, reimbursements don't happen due to the 30-day look back and stuff like that, you still think that they wouldn't have an agenda in that?
I don't know. I that's something I never thought about. I'm just throwing out ideas. I never really thought where on the issue insurance companies may come down, but I don't think they're going to lobby. They're going to spend money lobbying on behalf of either side. If anything, we've seen like with the No Surprises Act, they lobby against doctors so they can not pay as much. So I had another point I wanted to make and I just lost my train of thought. Sorry.
I think I interrupted your thought on that last question.
I don't know. So I know what I was thinking. One of the other things that I kind of argue is that would be a kind of an equalizer is if we say, okay, the practice of a nurse practitioner, for all intents and purposes, is a practice of medicine. I mean, I think if you asked even these NP and PA organizations, what's the difference between the practice of an NP or PA and the practice of medicine, they wouldn't be able to tell you because at least in Illinois, there really aren't any differences. I mean, they're allowed to diagnose, to test for, to treat disease, to prescribe medications. So what's the difference between the practice of medicine and NP practice? I think that there's really isn't one. And if that's the case, if they say they're equal and if there's not really a difference in the practice, then I would argue that they need to be held to the same standard of care as a physician. If you're going to, if you want to say you're just as good as a physician, and if you're doing all the same things as a physician, then you should be held to the same standard of care as a physician. And if you mess up, then your liability is that of what your reasonable physician would do because you're doing the same things as a physician. And I think that if that liability was extended, instead of saying you have to practice as a reasonable NP or PA, it's you have to practice as a reasonable physician. That would, I think, the added liability of that would give hospitals and it may give some of the NP and PA organizations a cause to sit back and think: are we going to be penny wise by not paying out as much money in the short term, but pound foolish by being subject to $7 million judgments or $21 million judgments when something gets missed? So something else to consider.
I'm curious as to why that hasn't happened yet. So as this expansion push is going across the country, have you seen that in any specific states where insurance has been modified?
No, because that's just the thing. It's and when everybody wants to be the same until all of a sudden there's an issue of liability, and it's like, whoa, wait a minute, I'm just it's that guy's fault. He was supervising me. I'm just the NP or PA. So that's I think that would be, and that would be something else that I think would be a good argument to make towards legislators to say, hey, if you want them to practice independently, then they really need to be, for all intents and purposes, they need to be held to the same standard as a physician. So, and I think we're kind of getting off of, well, I mean, I still guess that is still advocating for physician-led care, but I was going to say we're kind of getting off in the weeds a little bit.
No, it's all good. It's meant for it's meant for a discussion. This is meant for a discussion on all of this. And I don't believe Dr. Newman is here, and so we're not going to speak on match 2023 at all on this. Unless she came in last minute. We
Or
are
if
going.
Dr. Sullivan wants to. I mean, Dr. Sullivan, I don't know if you saw those numbers.
Yeah.
I saw the numbers. Yeah, we're actually doing a podcast for EP Monthly on this issue next week. So, and basically, you have to wonder why. What's changed so much in emergency medicine that there's more than 500 unmatched positions. I mean, it used to be back when I was in my residency. And right after that, I mean, you used to have to know somebody and have like awesome recommendations just to get a spot in a residency program. And now there's 500 spots that are unmatched. So, and what's the reason for it? I think that, I think there's a lot of reasons for it. I think that there's a kind of a scare put out through the emergency medicine community when there were some residents that were graduating last year that had trouble finding a job, because no one wants to go through all that training and then not be able to work. So I think that may have sent some shockwaves through emergency medicine in general. Now, again, when you talk about I don't even know what the desirable residencies were in the match this year. I just know that emergency medicine didn't fare very well. So I think the difficulty finding jobs last year may have caused some issues. Another one I think is there's a lot of like some of the contract management groups are sponsoring residencies, and they are churning out a lot of residents, and so the market's kind of getting flooded with residents, which makes it difficult to, again, it makes jobs, or I shouldn't say residents, or market's getting flooded with new attendings too. So when there's market saturation, again, there's going to be less jobs. So why would you want to go spend 3 or 4 years in a residency where you're not guaranteed having a job when you get out? And I think going back to some of the issues with NPs and PAs taking over some of the jobs that would normally be had by an emergency physician. Again, if there's less jobs available, is there a disincentive due to a residency in that specialty? So, and yeah, the multifactorial causes, I mean, burnout, yeah, boarding, yeah, and who's going to do anything about boarding? That's been an issue for 20 years. So, and I think COVID-19, the impact in the past was substantial, but I think that's kind of going by the wayside now that COVID-19 is becoming more of a or less dangerous infection. We'll put it that way. You guys have any thoughts?
I was thinking, I mean, it is multifactorial, and the report came out during COVID in terms of like EM workforce, so it didn't help. I think current med students like really feel comfortable going into EM then, but I do see, I go to the ACGME website and I look over the past years of just how many more residency programs we have, and they're not all private equity. There are increasing spots within university positions as ERs become larger. They're requesting more residents for the classes. So it's not just like HCA. It's not just like private equity, but there has been a huge increase in EM residencies among nonprofit hospitals throughout these past several years. And I think that's really driven up so many more spots and opportunities for students to actually go into or soap into EM. I think that's a large part of it, actually, but I do think it did not help during COVID, that workforce report coming out. And I do think it deterred students from going, like, why would you go into a specialty dealing with this virus that, people are dying from? Like, people are not trying to do that. People want to live. So I do think that it was multifactorial, and that report did not help during COVID.
What about you, Andrew and Katie? You guys are being quiet lately. What do you guys think?
So I again with Edletta, it's multifactorial. I know for me as a third year, I'm not like too much. I know I hear a bunch of stuff about HCAs and how bad they are, and I don't really know what that means. I just hear that coming from a lot of physicians. So that's all I have on that.
Yeah, I mean, I agree with both of them on that. And I guess just, I'm trying to think of solutions here, of course, which is kind of the theme of this episode. And I can imagine that some solutions would be to become more stricter on these residencies that are popping up. I just think that the more stricter you are on the residencies, the more potential residence positions you then sacrifice potentially, because if a residency has to be shut down, well, now you're sort of ruining the lives of a lot of those residents within that residency, I guess, even if it is something that has just popped up, and they're not able to get all the procedures that they need because of the fact that it's just it's too difficult. So I don't know, I guess, what do you think Match 2024 is going to look like? If you had any guesses, is it going to keep getting worse, or what do you think?
I kind of think it'll level out, but that's a $1 million question right there. There's not really a way to predict. I think that we need to make emergency medicine take it back to its glory days and show people what a good residence, what a good specialty it is. I mean, and just going back to one other issue, there's a lot of people who go into emergency medicine because it's a good lifestyle. You can choose to work as many or as few shifts as you want, and set something up. But it's gotten to the point, I think, now with hospitals closing and more patients and more boarding, and less staffing in the hospitals, so there's more patients being boarded in the emergency department. The lifestyle issue maybe isn't as attractive because, yeah, maybe you get extra time off, but when you go to work, you're always inundated with patients and admits and boarding and everything else that goes along with that, and it becomes you go to work frustrated and you leave work frustrated, and maybe that's something else that needs to be addressed because people don't want to do that.
I think I'm sorry, go ahead, Katie.
Go ahead.
I was just going to say, I think it's going to require, as I think in EM, a lot of flexibility, but creativity, and even just hours worked. Maybe we'll see like as diverse as it is already with 8-hour shifts, 12-hour shifts. Maybe, it would be a 6-hour, 4-hour. I mean, I don't know. I feel like there would have to be creativity with telemedicine and more EM physicians doing that for rural settings. I think we obviously will have to pivot, and I think there would be more creativity in what it will look like to be an EM physician in the near future. I did want to say that one of our attendees had asked us, has there ever been any push to limit how PAs can switch from field to field without specialty training? And I just wanted to come back so we didn't overlook her question.
I've not heard of anything, so that's I've got just no info on that. So, but intuitively I would doubt it.
But Katie, I'm sorry, you had something.
My last thing was, as an IMG, of course, I see these numbers and I'm like, man, that maybe I'll get to match, so selfishly I'm like, oh my gosh, that's exciting. But I know that even though these numbers are really high, there's still thousands of students that go unmatched from the specialty that they choose, which is very unfortunate. And they don't get to go work unsupervised underneath a physician for a year. They go work at Target or have to wait a whole nother match cycle. So my opinion on this is maybe pushing towards some kind of program. I know it's kind of off topic, but like bridging. So the year that someone goes unmatched isn't just a waste and be more in a NPP-ish type role. I mean, that's what you're doing kind of underneath a physician. So you're gaining some kind of experience and not having a year of just working at Target or whatever.
Right. And I think that's an awesome idea.
So Andrew, if you want to go to the next slide, we are running up on time here. So unfortunately, Dr. Fletcher isn't here, but if you guys have been to our previous sessions, we will be having the health symposium in Baton Rouge at the state capitol for the day, and lunch will be provided. So sign up for that if you are attending Scientific Assembly. It'll be really fun. And then lastly, just a statement from AAEM, every practitioner in the ED has a moral duty to clarify or to clearly inform the patient of his or her training and qualifications to provide emergency care.
And then just keep in mind, in a lot of states, it's actually a law. In Illinois, a PA cannot reference themselves as a doctor. And there's actually a specific law regarding nurses who get a doctorate in nursing, that they must inform the patients that they are not a medical doctor, that they have a doctorate in nursing. So a lot of states have laws that specifically require that NPPs do that.
Yeah, and to the normal person, I mean, they don't know the difference. Even seeing a NP or PA, they're like, my doctor, and they say that they don't know the difference. So I think more education too, just to the general public on the different roles is important. And lastly, we have all these resources. Alita put it in the chat. So if you guys would like to learn more information about scope of practice and how these different organizations are advocating for physician-led practice, please check out these resources.
Just to emphasize, you guys, for the attendees, the joint statement that AAEM and ASAP and AAEM RSA did with several other CORD, several other EM organizations is in the chat. It's linked for this EM match, this match 2023. And then there is a link for the symposium. It is a pre-conference symposium. The actual itinerary is found in the link. And then just like Katie said, we have linked to policy positions on physician-led care, and please check out like Physicians for Patient Protection, the AMA at the state level. We can all get active that way in terms of lobbying. And then the book Patients at Risk, which I did purchase, that was written by two physicians, kind of actually gives a history of nurse practitioners and physician assistants and the education and moving forward to today. So please, please educate yourselves. I think the biggest takeaway, Dr. Sullivan, is that we actually have to be active. We have to know who the players are and educate ourselves as well as them, and kind of see from their stance, such as trying to save money. How do we argue that physician-led care is safe and in the end actually more affordable? And I think also personally being proud of being a physician. I don't see that pride. I think people are kind of like shunned to say they're physicians and to be proud of it. And I actually push that we should be proud of the sacrifice. It takes dedication to focus on one specialty versus flipping through multiples. As fun as that sounds, I think, you know, when it comes to doing research and taking care of patients of a specific nature, that takes perseverance. And I think in today's world, I don't see much of the, I guess people don't really appreciate it until they need it, right? So if you study one field of medicine and you study it very well, those individuals or patients who may need that dermatologist or that urologist are very specific specialties. I don't think people really understand like what it means to dedicate yourself to a specialty or something specific. And I think we should own that and be proud of it.
Well put.
Well said, Lita. And thank you, Dr. Sullivan, so much for your time today. It was really great to have you here for this discussion.
Hey, thanks for inviting me. And you got, I mean, if you've got any questions, you guys have my contact information. You can feel free to shoot me any other questions that come up. I'd be happy to try to answer them.
All right,
Thank
thank
you.
you. And that about wraps it up for our webinar series. So thank you everybody for attending. And we really appreciate all your time and attention, and good luck with all you'll do in the future.
We hope to see you all in April at Scientific Assembly.
All right, take care, everyone.
Take care, everyone. Good
Good
night.
night.